Dear colleagues, dear professors, at first I would like very thanks to invite for participate in such a conference about autologous stem cell transplantation for multiple myeloma and Latvian experience. Here you can see before 18 years the first transplant was performed only Estonian autologous transplant and allogeneic. But after that, after 1 year and after 2 years, next step was with Lithuanian patient and next Latvian. From 2004, we are the members of European bone marrow transplantation group with our numbers. Yes, our activity not so much, but we perform transplantation from 2000. A few words about Latvian population. Our area is 64,000 kilometers. Our population a little bit more than 2 million. Most recently date from April 2016 of 1,900,000. 67% urban population, 32% rural population, males 45% and 54% females, and population density per square kilometer 31. Incidence rate for patients with malignant neoplasms, total numbers a little bit more than 11,000, and per 100,000 population 576.0. And incidence and mortality rates for patients with malignant neoplasms in 2014 per 100,000 populations. Here you can see mortality and incidence rate 576.3. And a number of malignant neoplasms, new case in 2014. The registry records with multiple myeloma is 419 patients. Total numbers with multiple myeloma, newly 97 patients, and incidence 4.8. As you see from Eurostat date, then our neighbors, Swedes, seniors' expected life expectancy is higher than the European Union average. But the closest neighbors, Estonians and Lithuanians, it like us, it lagging behind the European average. Riga East University Hospital is a multi-field medical treatment institution in Latvia that provides extensive diagnostic and treatment to patients, carries out scientific research work and develops innovations, ensures training of young specialists, organize activities for public education and health improvement. The hospital is a base of training of students Riga Stradiņš University and University of Latvia. And chemotherapy and hematology clinic are located in Riga Eastern University Hospital. Chemotherapy and hematology clinic is the only highly specialized medical center that provides hematological disease diagnosis and treatment for adult patients in all Latvia. Chemotherapy and hematology clinic consists of chemotherapy department, outpatient department, and daycare department for cancer patients, the same for hematology patients. 3 hematology departments and 1 stem cell transplantation department. And total number of hematological beds in the clinic is 97. The first autologous stem cell transplant was performed in 2001, and today is very historical days for us because 15 May 2001 we performed the first transplant. The first allogeneic stem cell transplantation from a family donor was performed in 2006, and since 2006 started autologous transplantation for patients with multiple myeloma. Since 2006 up to May 2016, we have carried out of 147 autologous stem cell transplantation for patients with Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma, neuroblastoma, and Langerhans cell sarcoma. Total autologous transplant count is more than 200. Of these, 54 patients with multiple myeloma. From 2000, the department had 3 beds, and from 2006, 5 beds, and from June 2016, we will go to the new building, which we have 10 patients bed. Our activity from 2006 to 2016, May. Here you can see allogeneic transplantation count. We perform allogeneic transplant from family donor, and patients who need who is indications unrelated transplantations treated in Vilnius in Lithuania. Really. Per year, we can do approximately 20-25 transplantation, both autologous and allogeneic. Registered newly patients with multiple myeloma by age group. Yeah, we have a lot of very old patients, more than 65 years old. Yeah, here you can see men, 39. And female 57, and old is more than 65 years. Together in our clinic records of 500 patients with multiple myeloma, the average age of patients with multiple myeloma is 67, and 47% of patients are older than 70 years. Characteristic of myeloma patients. Diagnosis, mostly patients IgA G class myeloma, IgA A6, Benz-Jones 5, non-secretory 2, myeloma and amyloidosis 2 patients, 16 male and 34 female. Median age 49 years, and status before transplantation only 16% complete remission, and partial remission 84%. Before stem cell transplantation, chemotherapy was for 7 patients with vincristine, adriamycin, dexamethasone, endoxan 34 patients, and bortezomib and dexamethasone 9 patients. Until 2015, bortezomib in Latvia was only the third-line therapy, but from 2050, the second-line therapy. CD34 cell mobilization, we use cyclophosphamide 4 grams per square meter, plus colony stimulating factors. A number of apheresis from 1 maximum 2. Conditioning regimes with melphalan, 200 milligram per square meter, and median CD34 cells per kilo is 4.80. Engraftment neutrophils count more than 1.5, median days is 10, and thrombocyte platelets count more than 50,000, median 12 days. Median time from diagnosis to transplant 14 months. 60% or 30 patients relapse. Median time from transplant to relapse 22.9 months. Of 30 patients who were relapsing, 14 patients or 28% have died due to disease progression. Transplant-related mortality 0, and currently alive is 36 patients or 72%. Progression-free survival analysis. Progression-free survival median is 23 months. Overall survival median is not reached. Between female and male groups, overall survival analysis without statistical significance, but progress-free survival analysis, yes, female line is a little bit higher, but female groups is 2 times more than the male groups. And here you can see one of our patients, and our patient said, īstenībā tas man bija šoks, kad sāka veikt ķīmijterapiju, sapratu, ka man nav kur atkāpties. Depresijā neiekritu, dzīvoju. Un galvenais, mēģināju sevi noskaņot optimistiski. Cilvēks īstenībā var izturēt visu, ja grib. In fact, it was a shock to me. At the start of chemotherapy, I understand that I have no choice for stopping. Without falling into depression, I live, and most importantly, I try to turn myself optimistic. The human actually can to hold everything, if he want. And my acknowledgements, aš noriu padėkoti mūsu kolēgai Tāda Žvirblis, Igoris Truciukas, and very thanks my colleagues Marika Āboliņa and Professor Sandra Lēnēca. Thank you.
Thank you very much. Maybe some questions from audience. Yes, please. Professor.
Thank you. Thank you very much for this very good presentation. I have 2 questions. You have a very good overall survival, and that means that you treat efficiently at relapse. What are the drugs that you have actually at relapse? I mean, concerning the new drugs, do you have access to pomalidomide, carfilzomide?
No.
So how do you treat relapse?
How do you treat it now? With bortezomib, dexamethasone, endoxan, yeah. If you mean about Revlimid, lenalidomide, and thalidomide, for example, yeah, is such drugs not included in the reimbursement list. Yeah, it's pay for full.
And do you proceed to a second autologous stem cell transplantation?
Yes, for a second. Yeah. But at now we use bortezomib and combination, and for elderly patients sometimes melphalan with prednisolone.
One last question. You mentioned some amyloidosis.
Yeah.
What is your procedure in case you have AL amyloidosis without cardiac involvement?
Yes,
this is a controversial issue. Do you do autologous stem cell transplantation?
Yeah, I have one patient with liver, myeloma plus liver amyloidosis, and the second patient's renal amyloidosis and tongue.
Did you transplant them?
Yes, before one month.
Thank you.
And good results.
Well, I really was amazed about your survival curve. It was fabulous. It's more up to 60% or something like that, and you had followed the longest patient up to close to 10 years.
Yeah.
So I allude to what Laurent said before about double autologous. Did you do upfront tandem autologous transplants in these patients or not? Or you only made a second transplant at relapse?
No. I performed tandem transplant per 1 year, yes. But I know who patient, yes. It's very difficult questions because from I think from 6 tandem transplant, alive only 3. It's very difficult questions. I don't know future.
Well, I will continue with the first question concerning relapsed patients. what's the definition of your relapse? Because many patients who are carefully seen in the outpatient departments, they go ahead with laboratory values.
Yes, only laboratory values.
They don't develop clinical features of CRAB. So you then refer these patients for transplantation based on the level of monoclonal protein.
Yes, monitoring.
Only, or you look at CRABs in CRAB, you know, this
yes,
clinical symptom.
Biochemical paraprotein levels.
Paraprotein.
Yes, yes.
And you look at the time to progression. You treat the same way patients who show a progress before 6 months and after 6 months, for example, or you have different strategies because it shows the dynamic of the disease. It's a surrogate for genetic risk factors, but it works fine. So for those who will proceed with the disease before 6 months, so they should be switched to more aggressive treatment, I think.
Thank you very much. Thank you very much for a very nice presentation, and thank you for questions. Questions were from Professor Gardenet, from Professor Gostegarden, and Professor Helovetsky. And now, next speaker is Professor Helė Varaus from